right, there we go. All right, welcome everybody to our monthly rights training series. This is our last session for September, and our topic of discussion for September is reduction plans for rights restrictions. So as we all know, when we're using rights restrictions, we have to have some safeguards in place to really make sure that we are thoroughly discussing whether a restriction is necessary and appropriate, least restrictive, that the risk it's mitigating genuinely outweighs the risks around using a rights restriction, all of those different things. And in my opinion, one of the most important parts of those safeguards is the reduction plan. And it is something that we have historically struggled on. It is the most missed safeguard in our ISP reviews. And when I look at like findings that we're seeing from Liberty's reviews of provider rights restriction documentation, we also commonly see reduction plans that are missing or reduction plans that don't meet the division's expectations in those reviews. So this is a place we have seen, I will say, and I want to give credit where credit is due. We are seeing improvement in this, even from kind of the first initial trainings we had in this training series where we talked about the safeguards kind of all together. Just from that, we have seen a good amount of improvement in this from you all. You know, my staff report anecdotally that that they're seeing more and more good reduction plans, and the data is showing it too. So, you know, we can see that this is something you all have been working on, and we're doing better, but there's still definitely room for improvement. And so that's why this is a topic we're going to take a deep dive into this month. And also because this is one of the things that you all reported when we surveyed, one of the topics that you all wanted to know more about. So today we're going to talk about reduction plans. First, we're going to talk about why they're required and important, because I think sometimes we all of us, but you guys especially, you have so many priorities, so many guidelines to follow, so many, you know, red hints, SOPs, like you have to balance all of these different things. And sometimes it can feel like they're just boxes you have to check. They're things you have to do. They're kind of bureaucratic red tape that we have to have. Um, and when we feel that way about things, and I'm not saying anybody's doing it consciously or, you know, anything like that, but you know, there are things that I feel like that about. Like, I think it's natural. But when we feel like that about things and we aren't mindful of like the why they're there and the why they're so important, it gets easier to just kind of maybe phone it in a little, not intentionally again, but just you have so many things to do and to that you're responsible for, that sometimes things get, you know, put lower on the list of priorities to put your energy into. And so that's why I really want to talk about the why first and foremost. Then we're going to talk about what are the required components of a reduction plan. What is the bare minimum that if my team is reviewing a plan that you wrote and it has restrictions in it, what is the bare minimum we're going to look for reduction plans? Then we're going to talk about some things that are considerations for writing good reduction plans, because as with most things, there is some space between what is bare minimally compliant and what is really good and robust and meaningful. And so we're going to talk about some of those things. And then we're going to talk about, or then we're going to give some examples of compliant and non-compliant reduction plans, because I think sometimes talking about things is one thing, but sometimes it can be a challenge to connect that back to the specificity of our work and the situations we find ourselves in and that type of thing. And so I think for some folks, because we all learn different ways, examples can be helpful. And then we're going to talk about data collection and tracking related to reduction plans, and team review of reduction plans as you review restrictions twice a year or more often. So the why. Why are reduction plans important? When we are going to limit someone's fundamental human rights, and make no mistake, even if it seems minor, even if the participant doesn't seem bothered by it, any rights restriction that we're putting in place is a limitation on a human being's fundamental rights as a human. And on that basis alone, we cannot take it lightly. And we're doing it for a good reason. We're doing it with the best of intentions, and we're doing it because we've exhausted all other options, and that's okay. But it is still a big deal. And so when we are going to limit somebody's fundamental human rights, we must always be actively working to restore those rights. It is what any of us would want if our rights were being limited, and it is what we owe our participants. One of the ways that we do that is by creating a reduction plan and monitoring progress towards meeting the reduction criteria. The other way is what we talked about last month, those habilitation and behavior support pieces. So to me, the habilitation and the behavior support pieces and the reduction plan are kind of the two prongs of how we are meeting that expectation that we are always doing our level best to work towards restoring a person's rights to the greatest extent we can, as soon as we can. So with that, reduction plans functionally serve really two important purposes. They serve a really important philosophical purpose, but functionally, your reduction plan is what you should be looking at most at your semi-annual review. We require you to review all restrictions semi-annually, right? What do we want? We don't want you to just say, yep, there's still restrictions. We want you to be looking at, have things changed that would allow us to restore this person's rights, all or in part, by potentially reducing or eliminating this rights restriction. And a measuring stick for how we can frame those conversations is that reduction plan. And the other piece of it is that reduction plans give the person whose rights are being restricted a defined goal or criteria to work towards to have the team consider restoring their rights and reducing the restriction. And, you know, I think we owe our participants that, even if they don't fully understand it, because that's what we would want for ourselves, right? Like, you know, if you broke the law, you did something, and you got put on probation by a judge, that's a limitation of your rights because you're not supposed to drink or consort with other criminals. I don't know. There's probably a better way to say that. But like, there's things that you're supposed to do when you're on probation, rules that you have to follow that you don't have to follow if you're not on probation, right? That's a limitation of your rights put in place by a judge. So none of us would be okay with a judge saying, I'm putting you on probation and we'll come back and talk about it every 6 months. And that's all. Every last one of us would want to know, what do I need to do? What fine do I need to pay? What class do I need to take? What length of time is this supposed to be for me to have my rights restored? None of us would be okay with that being left indefinite or being left up to the judgment, the subjective judgment of whether we're still a risk to society or not of a judge or anybody, right? Like, and so we owe our participants the same thing. And so it is our responsibility, just like we would want for ourselves, to clearly lay out objectively what would it need to look like for the team to feel that it was safe enough to consider reduction. Any questions about that? Lisa, I see your question and we'll get to that. Okay. So that's why I wanted to start with why this is important, because if we really understand why it's important and we really truly believe that all of our participants do genuinely have the same rights as all of us, regardless of their disability, and that they are entitled to protections around their rights the same way we would want for ourselves in the same way that we are, it gets a lot harder to view this as just a box to check or you know, if we really truly believe that our participants' rights are our rights and we want to protect them the same way we would want our own protected, or that we would advocate to protect our own ourselves, then we can't just have a reduction plan that says the team will talk about it every 6 months, right? So now the requirements. Because if I'm being honest, it's somewhat rare that we review an ISP now where there's just nothing said for a reduction plan. That used to be more common, but we've, done training and stuff on this over the years. And so it's pretty rare where we just don't see anything. Most of the time when we see issues with a reduction plan, it isn't that there isn't one, it is that there is not a meaningful or minimally adequate one. So that's why I want to talk about the requirements. So first, the requirement is for when you have to have one. Every single restriction must have a reduction plan, full stop. There is not a restriction out there that does not require a reduction plan that meets the expectations that I'm going to get to on the next slide. Even when it is very unlikely that they will learn the skills or knowledge that they need to exercise that right safely. We still have to have a reduction plan. And that includes psych meds. And I think that that's a struggle for a lot of folks because they're like, well, the team isn't the prescriber. We can't reduce psych meds. You can't. You're absolutely correct. You can make recommendations to the prescriber to consider reduction. And so that is what, for a psych med, you're basing your reduction criteria around. But there must be a reduction plan in every single case where we're using a restriction. The reduction plan is developed by the participants team, but it is your role as the service coordinator to work with the team to develop a reduction plan that meets the requirements in division's policy. Because I know there are sometimes teams that you talk to that say, we don't think this should ever be reduced, and so we're not going to agree to a reduction plan. That is not acceptable. Our policies demand it. There is never a situation in which it is compliant or acceptable or meeting with the division's expectations to not have a reduction plan. And so that is a conversation to have. And if teams are really struggling with that, sharing resources that we have, like the policy manual, like the rights and restrictions SOP that has been approved to share externally, those are resources that make the expectations clear to help that you can use to help folks you're interacting with understand the expectations around this. So now, what are the requirements for a reduction plan? Because like I said, it isn't adequate to just have something that's labeled reduction plan, but that isn't a meaningful reduction plan. So at a minimum, the reduction plan for every rights restriction must be specific and measurable and objective. And I'm going to talk about those three first because they kind of tie together. They need to be specific so that, and what I mean by specific there is that it can't be something like, when they improve their coping skills. What does that mean? What coping skills? What does improvement look like? Do we have a list of coping skills? Or is it just coping skills in the grand scheme of things that could be called coping skills? Or are we going to decide what coping skills improvement looks like when we see it? Measurable. It has to be something that we can, that if any of you got hit by a truck tomorrow, whoever is covering that participant's case can pick up that plan and go look at some sort of measurement and say, yes, this person is making progress, but they haven't met their reduction plan. No, they aren't making progress. Or yes, they've met the reduction plan and we need to talk about reduction. Anybody should be able to pick up your ISP and figure out what they need to go look at to objectively determine, yes, this person has met this criteria that's been set, or no, they haven't. And they should draw the same conclusion. That's the other thing, is that, and that's kind of that objective piece, is everybody should look at a reduction plan and get the same thing from it. Everybody should know exactly what reduction looks like, and everybody should be able to look at the same set of information and reach the same conclusion about whether the participant has met or not met that criteria. So if we have a reduction plan that just says improve your coping skills, and I'm going to offer that as an example a lot because it's something we do see somewhat often. If you asked Dawn what improve your coping skills looks like, and you ask Lene what improve your coping skills looks like, and you ask me what improve your coping skills like, and I ask Sue what improve your coping skills looks like, are they all going to come up with the same answer? It would be really creepy if they did, like sort of Vulcan mind meld, but probably not, right? And that's a problem. Anytime that everybody who looks at that reduction plan isn't going to reach the same conclusion about what it means and when it's met or not met, those are signs that it is not specific, it is not measurable, it is not objective. And then the last piece is relevant. So even when it is specific, it's measurable, it's objective, if it has nothing to do with the risk being mitigated, that is also a problem. So say there's a sharps restriction and the rationale for that restriction is the participant engages in physical aggression and has a history of using sharps as weapons, right? So if the reduction plan is less than 5 target behaviors across 6 months, but if I go and look at their target behaviors and they have target behaviors of physical aggression and using weapons, but they also have target behaviors of verbal aggression and theft and elopement and this, that, or the other. Do they really need to have less than 5 of all of those things for us to decide that the risk of physical violence using sharps is reduced to the extent that maybe we could reduce this sharps restriction? Probably not. Maybe verbal aggression, because often verbal aggression is a precursor to physical aggression. But like the elopement, what does that have to do with, like, how is that necessary to demonstrate a reduced risk that you're going to take a scissors and stab somebody, right? So that's the other piece of this, is that you want to make sure that what you're using as a reduction plan actually measures the reduction of risk that is the reason we have that rights restriction. And that, it can be hard because, I mean, providers don't want to collect data on a bunch of extra things. They might give you grief about it, but it's so important to have a reduction plan that really speaks to what would a world look like where we think it would be safe for this person to not have this restriction or have this restriction reduced? And what are observable signs of that that we can then create a reduction criteria around? That's kind of, you should almost be reverse engineering that reduction criteria and thinking first about like, what would we need to see? What would that world look like where it's safe for this person to have this restriction reduced or eliminated? And what are things that we can see and measure that would be indicators that we're getting to that world? And that should be your reduction plan, whether there's already data collection for those things or not, whether they're in the BSP or not. None of that should influence what the team creates a reduction plan around if what is truly indicative of that reduced risk is something that's not in the FBA. Because sometimes there's more to demonstration of reduction than the actual instance of problem behaviors. And we'll get more into that here in a little bit. Then the last thing on this slide, and I don't want to create confusion, but I've had people come to me before and be like, we can't accept this reduction plan because it doesn't meet SMART criteria, right? And I'm like, well, not necessarily. So if you write a reduction plan that meets the SMART criteria, odds are it will likely meet at least the minimum expectations that we have for a reduction plan. But there are parts of the SMART criteria that aren't really an element of this in the way that they are for like our habilitation programs that have to have SMART goals. And one of the things that doesn't always apply here is timely. So sometimes we need a time boundary on a reduction plan, but we could create a reduction plan that says, you know, we might consider reducing the restriction of using bed rails to address fall risk when the person completes all their physical therapy goals, because we think that that will be an indication that their fall risk has reduced enough that we can get rid of these bed rails. It might take them 2 weeks or 2 months or 2 years to pass all their therapy goals. So we wouldn't necessarily need to put a time limit on that one. It's still objective, it's still specific. When they've met their physical therapy goals, the team will consider reduction, but it doesn't need a timeline. And so that's why that SMART criteria isn't expected. Now, there are some times where how you structure the reduction plan, it probably needs a time limit or a time, you know, element to it, but not every situation. And so that's why we kind of say specific, measurable, objective, and relevant. And you can get to those 4 things by following the SMART criteria, but that isn't the only way if it doesn't make sense based on what you're setting your criteria on. Any questions about this? Okay. So considerations. So these are things that are not necessarily part of those bare minimum elements of what a compliant reduction plan looks like, but these are things to think about and to talk about with teams when you're creating reduction plans, to write really good and meaningful reduction plans, and how we would want them done for ourselves if we were in our participants' shoes. Reduction criteria should be reasonable. We see, I don't know if a lot is the right word, but it is not uncommon for us to see an ISP where it says 0 incidents of any target behavior for 1 year. And I'm not going to say that there aren't situations where maybe that might be what is needed to demonstrate that it's truly safe to reduce somebody's restrictions. But in a lot of cases, that's not necessarily true. The bar that we set for considering reduction should be consistent with the amount of restriction we're mitigating with that restriction. So if it's a very high risk behavior, like say we're restricting fire starting materials because a participant burned down their last 3 group homes, yes, 0 fire starting or attempts to access fire starting materials for 1 year probably wouldn't be an unreasonable reduction criteria to set. Maybe even longer than 2 years, right? Or a year. But if it's, you know, something that's lower stakes, then we need to be reasonable. And sometimes 0 of that risk behavior for a whole year is setting the bar higher than that risk justifies. And sometimes I like to flip it and say, okay, you know, we've set the criteria at 0 episodes of physical aggression in a year to consider reduction of the sharps restriction. Would I introduce this same sharps restriction for somebody who has one single episode of physical aggression in a whole year? Because I'm saying that's what this person who has a history of physical aggression would need to show, is absolutely not even one, in order to think it's safe to reduce this restriction. But no one would let me suggest that we should introduce this restriction for somebody who has one episode of physical aggression a year, right? So if you think about it and say, you know, I wouldn't implement this for somebody who only ever had 5 incidents of physical aggression a year. So maybe 5 incidents of physical aggression is too high of a standard to say what safety to consider reduction looks like for whatever it is. And the other thing I want to be ask you to be mindful of here is restrictions aren't all or nothing. I think sometimes we create reduction plans with the idea in mind of like, what would it look like to be safe to have no restriction at all? That isn't what reduction plans are about. Reductions plans should be framed around what would it look like for us to decide that it's safe to take a baby step down, to go from no sharps, no forks, no nothing to supervised use of safety scissors and plastic forks. Like, nobody's saying that you have to set the, you know, reduction criteria around what it would take for everyone to think it's safe for you to take this person out and buy them a sword. We're saying, what would it look like for it to be safe for us to say, this person can start eating with forks again. We don't have to just go with spoons. Does that make sense? Any questions about that? So Scott asked, is it silly to say if the participant does not exhibit use of sharps and physical aggression for when they have no access to sharps? Should we word the reduction plan reflecting other behaviors? This is an excellent question and something I'm going to get to here in a slide or two, I think. So this consideration, reduction criteria should be based on the participant's skills, abilities, and behavior, not outside factors. We see this sometimes with relationship restrictions, especially if the person has a family member who was maybe abusive to them. And so their guardian says, we don't want them having contact with this family member anymore. And that's a restriction. Sometimes we'll see the reduction plan being when this relative is no longer acting like a crazy person, then we'll consider reduction. We're not going to set the reduction because this is a limitation of this participant's rights. We're not going to set reduction on something that is outside of them. The behavior they display, the skills they can learn, the knowledge they can learn, any of that. So in that situation, I tell people all the time, reframe it. The risk there isn't the crazy relative, because we all probably have a crazy relative or a friendship that was toxic or a past relationship that was toxic, right? Like we all have people in our lives that, you know, maybe aren't the best people to associate with. And sometimes we cut them out of our lives and sometimes we keep them in our lives and we just cope with any nonsense they bring to us. our participants might struggle to draw those boundaries and to cope with some of that. And so sometimes it does make sense to limit their interactions with folks in their life who aren't safe or who aren't, healthy relationships for them. But then it isn't the other person's behavior that is the risk. The risk is this participant doesn't have the ability to draw social boundaries, to, the coping skills to manage these relationships and keep themselves safe. So that's what we're going to teach. And that's what we're going to set reduction criteria around, not the other people, because there's always going to be crazy people. There's always going to be unsafe people that you might encounter in the course of your life. What is it that the participant, what is the skill or ability or knowledge that they don't have that makes it so that they can't manage it themselves? And then that's what we're going to teach. And that's what we're going to measure their learning of to determine when it might be safe to reduce that restriction. Tammy asked, can I give some good examples of reduction plans for people on psych meds? Yep, I got that in here too. You guys are getting ahead of my presentation. Good questions though. So for psych med restrictions, the reduction plan should be based on, like I said a little bit ago, when it might make sense to recommend to the prescribing physician that the med can be reduced. Because obviously none of us are the prescribing physician and our teams aren't either. And so all we can do is recommend a reduction. And so that's what we're framing our reduction plans around. But I will say, even though, how to prescribe a med is solely up to that prescribing physician, we also do have a responsibility to our participants to advocate for them, to be supported in the least restrictive manner possible, because studies show, data shows, research shows that people with people with developmental disabilities are medicated with psychotropic medications at a substantially higher rate than the general population. They are substantially more likely to be prescribed multiple psych meds across multiple classes than the general population. And we know that it is not uncommon for things that a lot of times our participants can't communicate. So when they're in pain or upset or things, it comes out in the form of behavior. And if we don't recognize that there's a medical issue that is causing pain, that's giving rise to this behavior or whatever, we take them to the psychiatrist and they're like, oh, physical aggression's up the meds, physical aggression's up, add a new psych med. And so our participants almost get, it's not saying that this is anyone's intention or that it happens in every case, but it is not uncommon for people with developmental disabilities to kind of just be drugged into compliance with psych meds. And so it's our responsibility to advocate for them and to, advocate for their healthcare with their physicians when appropriate. And so that's why we have that reduction criteria. It is a cue for the team to have a discussion about whether recommending reduction might be appropriate. And if the team really feels like reduction might be appropriate and the prescriber isn't open to it, the team can also make referrals for a second opinion if you feel like the team's concerns and that what's in the best interest of the participant and their quality of life isn't being acknowledged by their current prescribing physician. Just like we would get a second opinion ourselves or advocate for ourselves with our own doctors. A lot of our folks aren't able to do that. And so it is part of our responsibilities to help do that when it comes to psych meds specifically, when there are rights restrictions. When a provider utilizes the bulletin to make a psych med not a restriction, is there anything we should be looking for? So yeah, when a medication isn't restrictive, we don't have to have a reduction plan for it, right? But we're still going to look for if it seems to be impacting their functioning or their quality of life. Like, do they take their 5 o'clock meds and then fall asleep in their supper every night? Do they seem out of it after they take their medications? Those are indications that, a medication might be having some side effects or some impact on their quality of life that isn't in their best interest. And you might want to go back and have a conversation with their prescriber about it and discuss options and alternatives. What if the doctor says not to come back for reduction of medications as the participant is at the best level, or they will leave the participant? That's not okay. That's really, really, that's a concerning thing to hear from a physician. I don't want to get too deep into that because, you know, I want to be mindful of our time and to get through the whole presentation. But I would maybe like you to talk with you more about that, if that is something that you're seeing, because that's an attitude that, like, I take psych meds. I have a psychiatrist. I would not be okay with my psychiatrist saying that to me. Like, this is the best level of med for you, regardless of how you're feeling, regardless of, like, I only see you 45 minutes every 3 to 6 months, but I'm deciding that this is the best medication for you, regardless of how you're feeling or what's happening in your life. And don't come back to me and ask for a change in dose, or I will drop you as a patient. No psychiatrist would say that to any of us, right? And I wouldn't keep going to my psychiatrist if they said that to me. So I would hope that you're not encountering that. But if you are, I'd be interested to know more. What do we think of participants that are mostly nonverbal their whole life to be diagnosed with schizophrenia? How does the professional assess for that without individual self-reporting the usual symptoms? I mean, things like that. I mean, would I have questions about that? Possibly, but you know, we want to be careful about questioning physicians and decisions they make within their scope of practice. You're not questioning. It's always okay to ask questions, but because it's not, you know, it's not as if doctors never go rogue, or anything like that. But I've never seen anything that would explicitly prevent a doctor from making a diagnosis like that because somebody can't self-report symptoms. I'd be interested to hear about their rationale, but yeah, that would be difficult if somebody can't tell you that how their external behavior is happening is because of hallucinations they're having. I'm not sure. Another consideration, and I've touched on this a bit, it goes to that specific element. Please avoid vague terms like improve or reduce unless you're defining them further in your reduction plan. Because what constitutes an improvement or a reduction means different things to different people. So if somebody has physical aggression and they have a sharps restriction and they have 10 episodes of physical aggression and they tried to stab somebody to death last month, and then this month they have 8 episodes of physical aggression. That's a reduction. I'm pretty sure that's not what the team meant when they said when there's a reduction in physical aggression, we'll reduce the restriction. I hope not, right? So we need to be specific. It's so important, because if I asked every single one of you what reduction or improvement looks like, I would get 100 different answers. And so we have to be more specific. We have to say how much reduction, how much improvement, and what are the observable, measurable elements of that. And this one, I touched on it a little bit, or I guess I touched on the piece where it's not all or nothing. But the other element of it that I think some teams and some folks struggle with is they think that if we set this reduction plan and the person meets it, but we still think that there's risk there and we still think it's not safe, we have to reduce when they meet that reduction plan. And that is also not the case. Setting a reduction plan does not mean the team is obligated to reduce the restriction when that criteria is met. Reduction plans aren't binding. It is just a cue that the team needs to have a conversation about whether you feel it is safe to make a reduction at that time. And it needs to be a meaningful conversation, because and sometimes you need to maybe hold folks' feet to the fire. This is what we said a world would look like where we would think it was safe for this person to have their rights restored, at least in part. And now we're saying that's not the case. So what is it about this world that we're in that they've met this criteria that we set out, where we said this is what safety to restore their rights in part would look like? And now we're saying it's not. So we have to have that conversation. And if the team genuinely feels that there is still risk, that's okay. But we have to make sure that we're not just, that we're being reasonable about it. Because there are some people that see even a shred of risk as enough risk to justify any rights restriction. And so we have to be a bit more critical than that. But if the team genuinely feels like there's still risk there, then you can make the decision not to reduce the rights restriction. There might be multiple factors that tell us that there's still risk that makes a reduction unsafe. And it could be a factor that we didn't anticipate a year ago or 2 years ago when we set the reduction criteria. But when a person meets that reduction plan and the team still feels reduction isn't safe, you have to create a new reduction plan. And it needs to be based around whatever those factors are outside of this reduction criteria that you had that they met, that is telling you it's still not safe.
So, Sarah, what happens if the entire team agrees that the reduction needs to happen and that we should lighten the restrictions that are in place, but the guardian says no?
It is not entirely up to the guardian. Guardians choose for participants to be in our services. They choose their service providers and what services they receive. But they are not the final decision maker, especially when it comes to how we follow our policies that demand that we protect participant rights. Now, you're not going to just say, oh, I'm sorry, majority rules, your opinion doesn't count. There need to be conversations around that, because to the best of your abilities, we want the whole team to feel good about what's in the plan and making changes to the plan. And so I wouldn't let a guardian tie it up forever, but we need to find ways to help them understand and see what the rest of the team is seeing, if the rest of the team genuinely feels reduction is safe.
Sarah, can I jump in really quickly with this one? Only because it's really important, if you have a situation like that as a service coordinator, to touch base with your supervisor and or your administrator, just because a lot of times a guardian is leading from fear and experience. They're the expert most of the time on that person. And so we really want to make sure that we understand where they're coming from and then meet them where they are to create that relationship and understanding, because you never want to be in a situation where the entire team is completely against the guardian. That is not ever our goal. And sometimes it just takes kind of that outside person to say, okay, look, this is what we're looking at. And maybe it's a job of, what is the worst case scenario here? What are we actually fearful of? And that's usually where the guardian mindset is. And so we do want to be understanding of that and have that conversation. I just would highly encourage you, if you have that situation where it's the team against the guardian, please connect with your supervisor and your administrator, and let's repair that relationship and have that conversation.
And sometimes it doesn't even mean that there's necessarily hostility or hard feelings, but yeah, guardians often, especially when they're family members and parents, are their perception of what safety and risk looks like might be different from the rest of us. And nobody is right or wrong. Everybody has their different perspectives. And I've actually attended a team meeting where a guardian was really hanging on to some really overly restrictive stuff. And I attended the team meeting, and, you know, that one did get a bit heated, and they were like, you know, you don't know my son, you don't care about my son, et cetera, et cetera. And I'm like, I don't come here and make the medium bucks every day because I don't care about the people that we support. But I care about them differently, right? But while they have the luxury of focusing all of their care on their loved one, I have to care about everybody in our system. I have to care about the rules. I have to care about the, you know, our responsibilities to taxpayers and our federal overlords. Like, those are a lot of different things to balance. And so helping them understand where you're coming from, asking them, I think like what you said, Lene, about like asking them to articulate what they feel the risk still is can be really helpful, because I like to ask questions, because sometimes asking questions, people realize that they don't have good or reasonable answers to them. And that can help them come around to the perspective that you have without being confrontational and saying you're wrong. So I think there's a lot of different ways, and we talked about more. If you weren't able to attend it, all of the videos from all of the past sessions we've had are up now in SharePoint that you all can go back and watch. And if there are any sessions you missed, I really encourage you to do so. But we had a whole month that focused on guardianship, and we talked a lot about, you know, what a guardian's authorities are and aren't, how to, you know, advice or thoughts for managing those difficult conversations, and a lot of that stuff. So if you weren't there for that month, I want to say it was maybe May. Somewhere this spring, I think. So if you missed that one, I would really encourage you to go back and watch it. A really good discussion. Okay. And this goes to, I think, Scott's question. So sometimes it doesn't make sense to set your reduction criteria around the specific high risk behavior that the restriction is intended to prevent. So I'm going to go back to my fire starting example. Dawn, I'm sorry, I'm full of bloodthirsty examples again today. She likes to tease me about it. So we have a participant who has a restriction on fire starting materials, and because they burned down their last 3 group homes. So we probably don't want to create reduction criteria that they won't burn down their group home for 1 year. Because if we're implementing that restriction of preventing them from accessing fire starting materials, we should not see them burn down their group home over the course of a year. That is not a sign necessarily that the reduction has, or that the risk has reduced. It is a sign that our plan is working and being followed, right? So for things like that, you want to think about what are other signs that tell us that if I put a book of matches in this person's hand tomorrow, they would probably commit an arson. Are they attempting to steal fire starting materials? Are they trying to buy them and we're preventing them? Are we finding them in their stuff and removing them? Are they, this is going to sound silly, but I saw it in a thing, and I'm not trying to call anybody out if this is your person, but I saw it in FBA where it described this person who has a history of fire starting will go around the yard and gather sticks and pile them up. And if you ask them why, they're like, because I'm going to burn this place down. Those are signs that even if the person hasn't successfully committed an arson, that if we removed this restriction, the risk is still there and they would still be likely to do so, right? So when that's the case, we want to set our criteria around, and we want to measure attempts to elope, attempts to access fire starting materials. What are the What are the things that we can see and hear and quantify that tell us that the risk is still there, even if the very bad thing that this restriction is in place to prevent doesn't happen? I thought those links were posted, Jill. I went and tested one of them and it worked the other day. I didn't test them all though.
So the PDF is there. I just found the PDF and you should be able to, I don't see the videos there. And if I'm looking in the wrong spot, could be user error. It's
The videos
Thursday,
were,
but I don't
when
see
I looked
them.
at it, the videos were there, but the PDFs weren't. So I sent the PDFs. Did she maybe take the videos down? We'll figure it out. If it's not there,
Yeah.
they're all uploaded to DHHS's YouTube. So we just have to get you guys the links to access them. We'll figure it out.
I will put the link to the service coordination training page in right now, and it should be on this page that you eventually should be able to find them. They should link then to the YouTube training business. But this is where they should all be eventually, the PDF right next to the video, but I believe it's under construction at the moment still, apparently.
Okay. I lied then. I'll work it out. It was there because I went back and watched one of mine and one of them in part, and I was like, I say a lot. Oh no, they're there. If you click on the session 1 or 2 links, it'll take you to the YouTube video.
Did I not start to say it could be user error? Jill did say that.
Fair enough. So they
it
are
is
there. We don't
My
have
apologies.
August. We don't have August posted yet. I think I sent that one to her and she's working on it. And after today, I'll get her the September ones too. So those are there. But yeah, if you missed that guardianship one, or any of the first few, like the first, I think 4 that we did were really foundational concepts of rights restrictions and safeguards and rights in general. So if you missed any of those, really encourage you to go back and watch those. Okay. So any questions about this piece? We've got sidetracked a little bit, but if the restriction, if it's followed, is going to entirely prevent the thing that is the risk, set your reduction criteria around other signs that it's still a risk, even if they're prevented from doing the highest risk thing. So say there's never any GERs for successful elopement, because we have alarms and because staff are alerted to follow them every time they try to elope, so they never actually leave staff supervision. So there's no successful elopement, there's no AWOL GER, but if they're still going to the door, or if they're still setting off the alarm and staff are having to go retrieve them, those are indicators that that risk is still there. And it also can be helpful to define what the first step of reduction might look like to help the team better envision how to set criteria that would indicate that reduction would be safe. So like I said earlier, restrictions aren't all or nothing. And so we need to think about setting reduction criteria around, like, when would it feel safe to take a step down, not to get rid of entirely. And so sometimes that can be a hard thing for people to think about or conceptualize. And so if we define what that first step down might look like, so if we have a restriction of all sharps, no forks, no scissors, no nothing, if we're struggling to set that reduction criteria, or if the team wants to set it as 0 for 1 year, we can kind of redirect that and reframe it and say, okay, let's think about like what our first step down might be. Maybe a first step down is letting them start to use forks supervised again. What would it look like? What would we need to see or hear that would tell us that it's safe enough to do that? Not safe enough for all sharps, but safe enough for that. Any questions about that? And even if you define what that first step of reduction might look like, you're not married to it. Like, we can't predict the future when we're setting reduction plans and things like that. people are complex, things change. We're not married to it, but you know, we can kind of frame things around in certain ways that help us decide with the information we have in this moment in time, what would the circumstances for safe reduction look like? Sarah, we'll come back to you. That's a little off topic, but I'll come back to that if we have time. Or I'm happy to chat with you offline, or probably still online, but not this online. All right, examples. So these examples are they're anonymized, but for the most part, they are verbatim things that we have seen in actual ISPs. So these aren't examples that I made up. So instead of saying participant needs to reduce the incidence of problem behaviors in order for the team to consider reducing this restriction. As we've talked about, what does reduce mean? What problem behaviors? For how long? So if they go from 10 1 month to 8 1 month, like that reduced. It is not a long-term reduction and it is not a substantial reduction, but it is a reduction. Does that meet? That's probably not what the team intended though. And so instead of saying that, say the ISP team will consider reduction when the participant has demonstrated 2 or fewer incidents of physical aggression in a 3-month period. Because we're saying what that reduction looks like. We're seeing reduction from wherever they are now down to 2 or fewer over a 3-month period. So it can't just be 1 month where they had 2 or fewer or 1 week where they had 2 or fewer. It has to be across that 3-month period. So that anybody who picks this up, this ISP that has this reduction plan, and it could go to that person's BSP data and say, yes, they are meeting this or no, they aren't. I've given this example a few times, but participant needs to exhibit improved coping skills. What coping skills? What does improvement look like? For how long? Not specific, not measurable. So instead, you could say the participant will display improved coping skills by meeting STO1 of their BSP for 3 consecutive months. Another one, instead of saying the team will review the restriction every 6 months to determine when reduction is appropriate. You have to do that. That's not optional. Like you have to review it every 6 months. That's not a reduction plan, right? It's not enough to just come together and say, yep, there's still restrictions every 6 months. Because what does that tell the participant about what they have to do or learn in order to have their rights restored to them? So instead of that, and this is, I'm trying to give examples of different ways that you could frame these, that it doesn't always have to be about HAB program data or BSP data. Like you can create reduction plans about a lot of different things as long as they are specific, measurable, and objective. So the ISP team will consider reduction when the participant meets the goals set by their physical therapist to reduce their fall risk. Some more examples. Here's where we have a psych med example. I think someone asked for one of those. So instead of saying the participant psychiatrist will make recommendations on reduction if and when they show improvement. Instead of saying that, because it puts all of the decision making with the prescriber, and ultimately they do make the final decision. But what we need to focus on for these reduction plans for psych meds is when will we make a recommendation to that prescriber that they might want to consider a reduction. And so instead, when the participant demonstrates 5 or fewer incidents of self-injurious behavior over a 6-month period, the team will consider recommending that the prescribing physician consider reduction. It doesn't have to be super elaborate or anything. It just has to have the right elements. It has to be measurable, it has to be specific, it has to be relevant and objective. instead of saying the participant's family member must demonstrate safe behavior towards them in order for the participant to be allowed to have contact with them. Like I said, reframing that towards what the participant can learn or what they can demonstrate. When the participant demonstrates improved ability to set safe boundaries with family members, as evidenced by passing STO3 in his appropriate social boundaries habilitation program for 6 consecutive months, the team will consider reduction of the restriction in contacting the family member. Any questions about any of that? Or we'll get into data. Oh, there's a question in the chat. Do you have recommendations for a reduction plan where a reduction was previously implemented and there was an immediate increase in behaviors for a medication increase? Yeah, so what I would say, and for medications or for any rights restrictions, if we make a reduction because based on the, none of us can see the future, but based on the observable signs of risk that we can see and that we can measure, we felt like it was safe to make a reduction, and we made that reduction and it turns out it wasn't. So then coming back to, do we just need to look at the same factors, but maybe increase the amount of time or the threshold? Or were there other things happening that we didn't have in our reduction criteria that might have told us that the risk was still there, even though the thing that we thought was indicative of the risk reduced? There were other things still happening that were, in hindsight, indicative of the risk, and maybe we form a reduction plan around that. So data collection, this is the other half of it. And this is something that we're, as we're seeing people write better and better reduction plans, because like I said, we are seeing improvement in this across our system over the last several months, especially. What we are seeing some struggles with now is that people are writing great reduction plans and they're saying when there's less of X for this period of, when there's less than X amount of this over this period of time, we'll consider reduction of the restriction. But then when I go to the data being kept by the provider, it's not being measured. So the reason it's important for your reduction plans to be measurable is so that we can then measure them and use that to determine if the reduction criteria is met or not, whether we should consider reduction or not. And so so anything we're creating a reduction plan around has to be being measured and documented so that we have that to go back to evaluate, are they meeting our reduction criteria that we set or not? And sometimes it's really simple because it's a HAP program or it's a BSP or it's reports you're getting from their therapist or their physical therapist or what have you. Sometimes it's things that'll be in GERs. But sometimes it's not. Going back to my fire starting example, if our restriction is working, they're not burning anything down, right? And so if they have if we're measuring in their BSP incidences where they set something on fire, and we set our reduction plan around those other risk factors, like are they attempting to access fire starting materials? Are they collecting sticks and saying, I'm going to burn this place to the ground? Are they making threats, etc.? But then we go to the BSP and they're only measuring successful fire starting, then we don't actually know if the risk is still there or not, if we're seeing those other risk factors, unless we're measuring for those attempts or those threats or those types of things. So, and the reason that this is so important, I mean, it's what the team should be reviewing when you review semi-annually, is the measurement of the risk factors and whether the risk is reduced or not. It's also important because that's something that human legal rights committees that are required to review and give approval for these restrictions. Those are things that they should be reviewing too, and they really shouldn't be approving rights restrictions when the data doesn't support that there is adequate risk to justify that rights restriction. And I think sometimes, and I see this happen often, where the provider is like, well, they're doing XYZ all the time. When we go to the GERs, when we go to the T-logs, when we go to the behavioral data, it's not it's not as significant as they perceive it. It's not really happening all the time. But because when it does happen, it's really noteworthy, those incidences of it happening stick in their brain, and all of the days where it didn't happen, you don't think of as much. And so it's really easy for our brains anecdotally to trick us into thinking a problem is much more severe or frequent or significant than if we kept objective data, the data would actually show. And that can be something that can be a tool that you can use. Again, like if you're having a conversation where the guardian is really struggling with it or the provider is really struggling with consideration of reduction, instead of just going off your anecdotal things or what you can bring to the top of your mind, because that's usually going to be when things didn't go right, the data is something that concrete that you can point to say, I understand that when this happens, it's scary and that those things are, easy to bring to mind. But the data is showing that is so rare and that the risk isn't quite as we're perceiving it. And so we need to really focus in on what the evidence is telling us the risk is in our consideration of, and that doesn't necessarily mean that reduction is appropriate. I don't want folks thinking I'm saying use data as a crowbar to make people see things your way, but it can be something you can frame the conversation around to help people be reasonable and be realistic about what the risk is and what changes or lack thereof might be appropriate. And why is this important? I touch on this, but reduction plans don't do us any good. We've talked about why reduction plans are important, but they don't do us any good if we aren't able to track and quantify a person's progress or lack thereof. And if we aren't meaningfully reviewing progress and considering reduction when we see progress, then our reduction plans are performative. They're just a box that we're checking, just a piece of bureaucratic red tape that we have to write down something, a sentence in a plan to meet, and not a meaningful safeguard for a human being's rights. And we have to make sure that we are writing and treating reduction plans as what they are, or as what they're intended to be, which is a meaningful safeguard of folks' rights. And lastly, your team review. And we've touched on some elements of this, but specifically, so you're reviewing every restriction at least semi-annually, right? That's the requirement. Maybe more often, but at least semi-annually. Part of what you're discussing is whether it isn't just, like I've said semi-jokingly, the point of that semi-annual review isn't for the team to say, yep, there's still restrictions and then move on to other topics. We require semi-annual review of those restrictions, and that means reviewing whether the restriction continues to be necessary and appropriate, whether it continues to be the least restrictive method by which we can mitigate that risk, and all of those different things. And so part of that should be reviewing a participant's progress towards the reduction plan using any data or evidence or documentation that you have had that the provider has kept, that you've gotten from physicians or therapists or whatever that might look like. Looking at that evidence, that data or whatever it might be, and saying, yes, they've met this, or yes, they're making progress, but they haven't met, or no, they haven't met. We're not even close yet. And if there isn't any data or documentation that the team can put their eyes on to objectively say, and everybody reach the same conclusion in looking at that data or that evidence, and say whether there's progress or not, whether it's met or not, that is a good sign that either your reduction plan needs work because it's not specific enough, because everybody can't look at the data and reach the same conclusion about whether or not the person met the criteria or not, or it's a sign that the corresponding data collection isn't really capturing what you need to meaningfully review whether they're making progress towards that reduction plan or not. And if the team is, if the person hasn't met the reduction criteria, most of the time a team is probably going to decide to continue the restriction. But just like reduction plans aren't binding and that you have to, you don't have to reduce a restriction just because a person meets that criteria, meeting that reduction criteria is not the only way that a team should consider a reduction of a restriction, because sometimes there are outside factors that nobody would have predicted that came in and changed the risk. I worked with a gentleman at BSDC that when he was in community-based services, eloped from his home, entered a neighbor's home, and harmed a child. And he has a diagnosis of pedophilia. He had some really, really substantial significant risks and some really unfortunate, history in which he harmed a child. Most people wouldn't believe me if I said he doesn't have any rights restrictions right now. He might be passed away now, but when I last knew him, when I last worked with him, he didn't have any rights restrictions. Did he stop being a pedophile? No. Is his risk but did his risk to children change? Yes. Why did it change? He had a massive heart attack and now he can barely walk. And when he moves, he's so slow. He is not chasing anybody down. He is not eloping and getting away from staff. Like, he's just physically incapable. So the thing that caused the risk that needed the restrictions didn't change, didn't go away, but something else happened that changed the risk that they presented. And so those restrictions could be reduced. So the reduction plan isn't the only pathway towards which a participant might demonstrate that it is safe to exercise their right safely or to not have that restriction anymore. And again, if they have met the reduction criteria, the team needs to have a real thoughtful conversation about whether they feel it is safe to reduce the restriction. This does not mean eliminating it entirely, and it does not mean that the team is obligated to reduce the restriction. The team can decide that even with the reduction criteria being met, there are still signs that the risk has not reduced and it is not safe to reduce a restriction. When this happens, we can't just, and that's something else that we have seen in plans, is that they met the reduction criteria and the team said, now we still don't feel it's safe, but they left those same reduction criteria in place. We can't do that because that reduction criteria is supposed to be what the world looks like, what we can measure, what we can see, what we can hear, what a world looks like where it's safe for this restriction to be reduced. And the world already looks like that if your reduction plan is met, but something else is telling you that there's still risk. So you have to create your reduction criteria around that. You can't leave the same ones in place because we're already in that world where it's met and we're still saying it's not safe to reduce the restriction. And what are the team's responsibilities? If some team members feel reduction is appropriate, and this kind of goes to the question earlier, because it isn't always a guardian, right? Sometimes it might be folks who work for the providers, sometimes it might be others. If some team members feel that reduction is appropriate, but others are struggling with the what ifs, it might be helpful to do reduction as a trial under very limited circumstances for a very small period of time without making the formal decision to reduce a restriction and take it out of the plan entirely. And, you know, you set it for a time limit, you set it for specific circumstances, and you say, if there's one sign of a concern, then we'll drop the trial and the restriction will continue. But if they make it through that trial, that is then further evidence that you can, you know, then talk around with the team, and that might help, you know, team members that are struggling, you know, see that the risk really has reduced, or see that, you know, this can be accommodated safely. So, any questions about that? But that's something where, if it's a gray area where the team, I've said this before with guardians, if the team all really agrees it's time to reduce a restriction, but the guardian is still really struggling, a trial can be helpful. It can be so that you're working with them, you're willing to compromise. It isn't all your, you know, it isn't a power struggle or like everybody ganging up on the guardian. It's, you know, let's see what this really looks like. Sometimes that can be a helpful strategy in you know, helping bring the team to consensus. So, questions or comments? I think I've answered everything except Sarah's question from the chat as we went through. Did anybody have any other questions? Again, feel free to unmute yourselves or drop it in the chat. I'm not seeing anybody pop up or anybody rush to unmute themselves. So even though it is a bit off topic, and Sarah, I would encourage you, this actually we did touch on and talk about in that May training about guardianship. So go back and watch that one for sure, because it'll get into it more deeply than I can today. But yeah, if a person doesn't have a guardian, they aren't going to have restrictions, because our regulations state that the restriction can only be used with the consent of a guardian or participant. And we have other policy states that if a participant chooses to have an intervention in place or used with them, then it is a choice and not a rights restriction. It has to be a free choice, which means we have to be prepared to discontinue it at any point that they change their mind. And a lack of objection is not the same as a choice. But if a participant truly chooses for an intervention to be used, then it isn't a rights restriction. And so putting those two things together, we can't have rights restrictions for people who don't have guardians, because they must continuously consent to them, not just one point in time consent, but continuously consent to them being used. And if at any time they withdraw their consent, we cannot continue to use that intervention. And so it is not a rights restriction. We aren't allowed to use it in a way that's a rights restriction, because they have withdrawn their consent for it at that point. So
Sarah.
So that doesn't mean you're necessarily going to remove those interventions. It's that you're going to reframe it around, you know, if the person is okay with it, you know, say it's room searches. We're going to ask, and we're going to say, is it okay if I search your room? And if they say yes, then we're going to search it for unsafe items potentially. But if they say no, we're going to respect that. There might be some other actions, non-restrictive actions, that we take to, you know, keep an eye on the situation. We might ask again later. But so if there are restrictions somebody's plan who doesn't have a guardian, you're going to talk about how to reframe those towards, you know, if the participant is okay with them, we're going to continue to maybe use some of those interventions. If they express that they don't want them at any point in time or in any given situation, verbally or otherwise, what are we going to do instead? What do we want staff to do? And being very clear in the safety plan, if the person says no, verbally or otherwise, you cannot do it. And distinguishing it from restrictions, which you do to implement safety regardless of that person's feelings about it in any given moment in time.
Hey, Sarah.
Mhm.
In line with that, for somebody who is their own guardian, but has a history and active behaviors of physical aggression that has resulted in staff using holds because they continually go either after staff or roommates. Now, when she's at baseline, we've had the conversation of keeping herself and others safe, but obviously when she's having an active behavior, she's oftentimes, she's not going to consent to a hold. What about those situations?
Yeah, so I would definitely encourage you all to go back to the guardianship talk because we did touch on these. So with holds, so if I'm walking down the street with Jillian, I don't have a guardian, Jillian doesn't have a guardian, but I just all of a sudden get a wild hair to dart out in front of a moving vehicle. And Jillian grabs me by the shirt and pulls me back. Technically, that's a physical hold, right? She limited my freedom of movement. Is anybody going to fault Jillian or say that she made an undue restriction on my life because she tackled me in an emergency when I was trying to run out in front of a moving vehicle? No. So if it is a true emergency, doing what they need to do just to maintain everyone's physical safety, that is still allowed and appropriate even for somebody who doesn't have a guardian.
Okay. Should agencies, since that's one that technically they wouldn't consent to in the moment, should agencies still be running then the ESI through their HLR, or
So
because
they
they are
can't
their
have
own guardian?
restrictions, and so it shouldn't be like an approved restriction within their safety plan. But regardless of whether it's in their plan or not, whether they agree to it or not, regardless of their guardianship status, every use of ESI or restraint, allowable, unallowable, whatever, has to be reviewed by an agency's Human Legal Rights Committee.
Okay.
Not as necessarily a rights restriction or a standing rights restriction. It's just in our regs. They have to review, in addition to reviewing rights restrictions that are being used by their agency, they have to review every allegation or suspicion of abuse, neglect, or exploitation, every use of a prohibited practice, every use of emergency safety intervention, and every situation in which the rights of a participant they serve may have been violated.
Okay.
So they would review it in that context. It would still go in an incident. It would still go in a
Just not
GER
on their,
because it
like-
still is under the critical incident reporting guidelines.
Okay.
But it would not necessarily be something you would name in their plan as a rights restriction.
Okay. So it's by incident versus like their normal HLR schedule. Okay.
Exactly. Any other questions today?
Sarah, just because I'm curious, besides psych meds, what's the most common restriction we see?
Oof. I don't know if that's something my team collects data on. We collect data on what is the most common thing we see that's a rights restriction that doesn't get identified as a rights restriction. And the answer to that is psych meds. Secondary to that, I would say safety devices and like medical and dietary stuff. But as far as what's the most common restriction, I don't know that I know that my team doesn't keep data to that level of detail. Erin, I don't think you do either as part of what you do for the HLRAC. So yeah, I don't think I can give that answer except just my best guess based on the many ISPs and that I've reviewed and rights restrictions I've talked about over the years. Any other questions about reduction plans? Like I've said, we've seen some really great improvement in this element of the restriction safeguards in the last year. My team has commented on it. We're seeing it in the data. And the data has improved overall on restriction safeguards. But in that improved data, this is still the most commonly missed safeguard. The second most commonly missed are habilitation plans, BSPs, and safety plans, which was our topic last month. If we could really shore up and get to a place where we're hitting the mark with reduction plans and we're making sure that every restriction is in a safety plan and everybody who needs a habilitation plan or a BSP has one, we would not be talking about this topic so much, maybe. Like those, if we could get those things right, you know, people are going to miss things. People are human. You guys are human. My team are human. Things are going to get missed. That's life. But if we could really nail these few elements that are high flyers in our findings, we would be in a lot better place. And so I appreciate you all, the work that you put into this so far, because we can see that you all are putting work into this. We appreciate that. We appreciate you making time to, you know, learn and grow your knowledge on these topics every month. Greatly appreciate your engagement, the questions you ask, the conversations that you guys create opportunities for. And so if there isn't anything else, again, really appreciate all of you making time, appreciate all of you and the hard work that you do related to this and in general. And if there's ever anything my team or I can do to help you better understand these things or make your lives easier or support you in conversations or with talking points, never hesitate to reach out. We always want to help. And I know the same with your SDAs, supervisors. That's what we're here for. So if there's nothing else, we will definitely let you guys go. Happy Thursday. Have a great rest of your day.
I got a quick question, Sarah.
Oh.
For the November one, I think it ends up the second session falls on Thanksgiving.
Yeah, I
Are you
need to
gonna
move that one around. I think
Okay.
there's one that might fall nearish to Christmas too. We might
Okay.
need to move those both November and December to earlier in the month to avoid, because even if they're not on a holiday, you know, half of everyone, especially if you worked here for a long time, doesn't work between Christmas and New Year's. And so to maximize opportunities for people to attend if they want to, I'm probably going to move those up to earlier in the month.
Okay, thank you.
Yeah, have a great day, guys.
Bye, everyone.